आप वीडियो पे स्टॉप कर लीजिए और म्यूट कर लीजिए।
Hello, myself Dr. Ripal. I am working as an associate IVF specialist at Wings Hospital, and today we are going to talk about the optimization of IUI in today's era. Hope you all are doing well. My fellows are doing well, and everything is fine in their family. And just we are going to start in 2 minutes. I am just starting my screen share. Okay. Okay, so intrauterine insemination in today's era. First, we will discuss that why in this today's era of enormously growing IVF, why there is need to optimize the IUI. So we all know these facts. What are the facts that we know already? That IUI is a low success treatment. Yes, definitely in good prognosis patient also 15 to 20%. We all know that there are count and motility limitations to perform IUI, and it does not help us to evaluate the quality of the female gametes and male gametes either. And tubes has to be patent. So these are the limitations that can be overcome by IVF. But still, we need to optimize. We want to optimize IUI. Why? Okay, so knowing these limitations, we still want to optimize IUI. Why? Because it is simple, non-invasive, more acceptable psychologically and financially to the couples. It has less body involvement, less risk, less injections, low risk of OHSS, and less financial involvement. So yes, in good prognosis patient, we definitely want to optimize our IUI so that we can give more and more results. Okay, so guys, let's start our optimization. What will we cover in this lecture? So, when exactly we will opt for IUI, we will see for its precise indications in current scenario. We will study that what male and female factor we need to take care before deciding that we will perform IUI in this concerned couple. How will you do? Which drugs will you use? What trigger will you use? How will you optimize the technique? Will you give luteal phase support or not? How many cycles will you opt for? Is there any role of newer logistics? When will you decide to move from IUI to IVF? And something about poor responders. So let's start. First step, precise indications. Before deciding that whether to do IUI or not, we should know its precise indications. So these are some latest ASRM guidelines of 2020 that says that there are 6 to 7 precise indication in which cases we will go for IUI. So in case of female, these indications are unexplained infertility, cervical abnormalities or stenosis, anovulation, and third-party reproduction, and problems, fertility preservation before vasectomy. Now in male part, first reason is donor IUI, azoospermic patient. The second most common reason is mild male subfertility. Then problems with sperm delivery like retrograde ejaculation, hypospadias, and the rarest reason is fertility preservation before vasectomy, any testicular surgery, or anti-cancer treatment. In this case scenario, if we will do IUI, we can achieve more success. Okay, so which are the male and female factors which we need to take into consideration before deciding IUI? So this is a very good randomized multi-center clinical trial which have analyzed almost more than 2000 cycles, and it relates the sperm factors or the semen parameters with the results of IUI. So as you can see the results, higher total motile count was associated with greater live birth rate. That is, the count between 15 to 20 million is associated with almost around 15% result as compared to Severe oligospermic patient, that is less than 5 million count, only 5% result. So that is a clear one-to-one result, that as the count and motility of the patient is high, the result of success, the result of IUI will be better. Okay, so what do we conclude? Sperm count, motility, these are the two most important parameters for case selection. Mild male subfertility, that is defined as the count is between 10 to 20 million and the motility is between 10 to 20%, has good prognosis. So we will train our mind to counsel the patients in such a way that those patients who are falling into less than 10 million count, less than 10% motility, we will advise and try to counsel these couples into more direction of IVF rather than to go for IUI. Okay, now something about the sperm DNA fragmentation index. This is a very nice prospective study of 105 IUI cycles that relates the results of DFI. So as you can see that the abnormal semen parameters are associated with positive DFI result. So, but the clinical pregnancy rate, there is no difference. Like, see, this is DNA fragmentation test positive, matlab it is more than 30%, and DFI negative, that is less than 30%. But if you will compare the clinical pregnancy rate and the pregnancy rate, there is no significant difference between it. So there was no significant difference in pregnancy rate in IUI cycle. So do we order DFI in every IUI cycle? No, there is no need. DFI is important only from the counseling point of view, not from the treatment point of view. So no need to routinely use DNA fragmentation test before IUI cycles. This is another study, retrospective analysis of more than 1,000 cycles, and this study relates the rate of abortion with the rate of DFI. As you can see that there is no clinically significant difference in the pregnancy rate, but yes, there is a significant difference between the abortion rate. This is low DFI, medium DFI, and high DFI. When you will see the abortion rate, the high DFI has the highest abortion rate. So early abortion rate among these groups, the high DFI has almost more than double the rate of abortion as compared to medium and low DFI, right? So what is the conclusion? Routine use of DFI is not recommended in IUI, but if the couple wants to wait for natural cycle intercourse or expectant management, then DFI is helpful only from the counseling point of view. Okay, now we will move on to the factors, that what factors we will take into consideration before deciding the indications of IUI. So obviously, in case of female, age is the most important factor. Cause of infertility is the second most important factor. So age, as you can see, as the age of the female is less, younger the age, more the results. And indication-wise, unexplained infertility, cervical factor has more result compared to endometriosis and male factor. So what is the conclusion? The conclusion is IUI requires to be accompanied by proper patient selection. Okay, so what is the conclusion? The conclusion is the success of IUI will definitely depend on the cause of male and female infertility. So yes, we will definitely study into detail what is the male cause and what is the female cause. Mild male subfertility has good prognosis. Routine use of DFI is not recommended. It has only the role in counseling. If the female's age is less than 35 years, cervical factor, unexplained infertility, PCOS, mild endometriosis, these are the good prognosis patients that can give more results of IUI, right? Okay. So first step we have optimized. How will we select our patient? That we have optimized. Now we will move on to, we have selected our patient. Now how will you decide that which drug I will use and in what dose? Okay, so first we will start with whether we will perform oral, that is oral ovulation induction drug IUI, or we will perform gonadotropin IUI. So there are very recent studies now on that gonadotropin IUI gives the best results. Let's see the evidence. This is the comparison between clomiphene and letrozole in patients with unexplained infertility, and as you can see that as compared to letrozole and clomiphene, there is no difference in clinical pregnancy rate, but Letrose reduces the miscarriage rate and results into unifollicular enlargement that has good prognosis. Okay, so when we need to choose between clomiphene and letrose, letrose is an effective treatment because it has likelihood to improve dominant follicles, that to monofollicular enlargement, and reduces the miscarriage rate. So we will use letrozole in IUI. Okay. Now, this is a very nice network meta-analysis that has analyzed 26 studies involving more than 5,000 women. So what it has concluded that IUI with gonadotropins ranked highest on live birth and ongoing pregnancy rate. But along with it, it also leads to increase in multiple pregnancy rates. So two things are clear. We will perform IUI with gonadotropin in plus letrozole, but taking into our consideration the strict cancellation criteria because the rate of multiple pregnancy are also higher along with live birth rate in case of gonadotropin IUI. This is a very nice recommendation given by Canadian Fertility and Andrology Society. So higher gonadotropin dose is associated with higher multiple pregnancy rate, but along with it, higher live birth rate. So we have to balance. Gonadotropin IUI can be offered to couples with unexplained infertility, but at the same time, we should make our patients aware that it is associated with higher multiple pregnancy rate also. So we need to keep in our mind strict cancellation criteria when we are opting for gonadotropin IUI. What are the strict cancellation criteria? This is the European study, right? The cancellation criteria, no more than 3 follicles, more than 14 mm. In case of IUI with gonadotropin, with letrose, this is our aim. But in Indian scenario where multiple pregnancy is easily acceptable, in Europe, we don't accept multiple pregnancy. They are not ready to accept it. They want single child. So they have very strict cancellation criteria. But in India, they are easily accepting the multiple pregnancy and even triplets also, right? So in India, as per the clinical scenario, our cancellation criteria or our main aim of IUI will be at least 2 to 3 follicles, more than 14 mm. On the 9th or 10th day of stimulation. In India, this is our aim of IUI. Okay. Now, IUI is something which we will not focus on only follicular axis. We need to focus on endometrial axis also because along with the dominant follicle, we need good endometrium for our result. So this study evaluates the effect of gonadotropins on endometrial thickness. And what does it say? It says that as you increase the dose of gonadotropin, it does increase the endometrial thickness. But what is the exact dose of gonadotropin that will lead to optimal endometrial thickness? That we don't know. But yes, increasing the dose of gonadotropin, that is, clinical pregnancy rate is positively related to the dose of gonadotropins at the same time on endometrial thickness. And increasing endometrial thickness is associated with the dose of gonadotropin administered. So in short, increasing the gonadotropin dose will lead to increase in endometrial thickness. How much increase? That we don't know. Okay. Now, what dose will we use when we start our IUI and what we will use? RFSH, HMG, combination of both, what? Okay, so that's a very nice article published in Springer in 2018. Are we really choosing the correct FSH starting dose during controlled ovarian stimulation for IUI? Potential application of a normogram based on women's age and markers of ovarian reserve. Okay, so what they have done is they have prepared a normogram of the starting dose of IUI patients. This is the distribution of the FSH starting dose. The gray is given by the clinicians and the black, it has been calculated as per the normogram. And what it says is that the most of the dose coincides with the 75 IU of recombinant FSH. Okay, so it just clicks on our mind that either 62.5 or 75 IU in case of normal responder is the basic starting dose in case of recombinant FSH. But it is not true for hyperresponder, right? Now, what will we use? Recombinant FSH or HMG? How will we decide? So this is a very nice randomized control trial in 2014 that compares HMG versus FSH in case of IUI. And as you can see, in the clinical pregnancy rate, there is no difference between FSH and HMG. But when you will see the results of OHSS, almost in case of HMG, the OHSS rate were nil. And in case of FSH, it was 4.5. So what we will think that there is no difference in terms of ongoing pregnancy rate. So in younger women, normal responder, good prognosis, no difference, whether we will use HMG or FSH. But yes, in case of hyperresponder, in case of PCO, we will think twice because HMG leads to decreased OHSS rate. So we can train our mind that when we see hyperresponder patient more than 5 AMH, not ready for IVF, wants to go for IUI, we can think of using HMG. HMG, however, is safer than the RFSH in terms of OHSS risk. Okay. Okay, so regarding which drugs we will use and in what dose, we conclude that in normal responder patients, we can start from the routine dose of FSH, that is 62.5 or 75 IU in normal responder less than 35 years of age. Think of low dose FSH in case of hyperresponder, and that is called as chronic low dose step-up protocol. In hyperresponder, we can start from 37.5 IU of RFSH. We can increase by 12 units every 6 days, and we can do that up to 62.5 if needed. If the age of the women is more than 35 years, it is hyperresponder, better to use HMG because it definitely leads to decrease in rate of OHSS. In case of oral drugs, we have already concluded that letrozole is better than clomiphene in case of gonadotropin IUI. Okay, so we have selected our patient. We have selected which drug we will use, in what dose we will use. We have done that. Now, the third step is how will we trigger and what is the role, or is there any role of Doppler in IUI or not? Before moving to trigger of IUI and knowing the role of Doppler, I would just like to say that when do we call our patient for follow-up? In case of HMG, if we give 75 international unit alternate day or either 150 unit alternate day, we will call our patient on 9th or 10th day when her 4 doses will be completed. And in case of recombinant FSH, we will give the daily dose of either 62.5 or 75 IU, and we will call the patient on the 9th day of stimulation. Okay. Okay, now moving on to trigger and knowing that what is the role of Doppler. Now, what triggers are available with us in case of IUI? It is not that in IUI we cannot use agonist trigger. We can definitely use. So let's study. First of all, the question is there need to trigger? Why? We can just wait and allow the follicle to rupture on its own. What does the evidence say? Effect of HCG triggered ovulation and pregnancy outcome in IUI. It's a very nice retrospective cohort study which have analyzed more than 5,000 cycles, and it has compared the clinical pregnancy along with live birth rate. And what it concluded that giving HCG for rupture of the follicle definitely leads to more live birth rate and more clinical pregnancy rate. So one thing is clear, we will not go for natural cycle IUI. We will definitely trigger the IUI. Okay, now how will we trigger? Can we use agonist trigger? Yes, can we use? Why we cannot use? Okay, so this is the study comparing the GnRH agonist trigger versus HCG trigger in IUI. It's a very nice randomized controlled trial that has analyzed 197 IUI cycle. And as you can see, that between agonist triggered cycle and HCG triggered cycle, which are almost equal in number, there is no clinical pregnancy rate difference. So clinically, there is nothing like that. If we use agonist trigger, we will lead to less pregnancy or less result or less clinical pregnancy rate. So the conclusion is we can use. It is the clinical pregnancy rate with higher with HCG, but statistically there was no statistical difference. So value-wise, yes, biochemical and clinical pregnancy rate were higher, but statistically the results were not significant. So definitely we can go for agonist trigger in IUI. Now when? Okay, so when we can think of agonist trigger in IUI? In PCO patient, in a very severe hyperresponder patient who have more than 5 AMH, where the risk of OHSS is very high, where we are scared that whether we need to convert this cycle of IUI into IVF or not. So better to use agonist trigger. So this is a very nice randomized control trial evaluating only PCO patient. As you can see the OHSS rate. The clinical pregnancy rate is almost 30% and 27%. So no statistical difference between the clinical pregnancy rate. But OHSS rate is 0% in agonist trigger as compared to HCG where it is 1. So when we are in the fear of converting our IUI cycle into IVF, we can give a second thought of using agonist trigger in IUI as well to prevent OHSS. Okay, so now we have decided that we will trigger this patient with HCG or we will trigger this patient with agonist. But then when will you perform IUI? 36 hours later, 48 hours later, or 40 hours later? So it's a very nice study. The effect of delaying IUI till 48 hours after HCG injection on pregnancy rate. In simple words, it means that post-rupture IUI is better or pre-rupture IUI is better. Let's see the conclusion. There is a lot of controversy that surrounds this question, that whether we should document the sonographic rupture of follicle and then should perform the IUI, or we can do the IUI just as a routine, like 36 hours or 38 hours after giving HCG. So this study showed a statistically significant increase in pregnancy rate up to 22%. Performing IUI 48 hours after HCG triggered compared to 10% in patients having the procedure done 12 hours earlier. But do we do that clinically really? No, we don't do that. We don't sonographically do the follicular rupture study and then do the IUI. So, okay, the study says that, but then practically speaking, my experience says that there is no point in delaying the IUI more than 40 hours later. So we in our clinical practice always perform the IUI between 36 to 40 hours. And we don't sonographically see the follicular rupture because it does not make sense and it is not going to increase your results like 2-fold or 3-fold. So clinically, statistically significant difference is not there. So we are at present in our clinic not performing IUI more than 40 hours later. Okay, now how will you trigger? You will trigger by HCG, you have decided, but what is the optimum follicular size? I need to explain to you guys that the Letrose and the clomiphene, the gonadotropin, all these three works physiologically in a different way. So the dominant follicle which they will create will also differ. The gonadotropin and Letrose will lead to the dominant follicle size, which will be around 18 to 20 mm. But when we are using CC, the size of the follicle will be around 20 to 21 mm. So in our case, when we have decided that Letrose is better than CC, gonadotropin IUI is better. So in our cycle, we will not wait more than 20 mm. 18 to 20 mm is our limit. So that is that also. But the other thing is that, yes, along with the follicle, we need to maintain the endometrial axis also. So the optimum endometrial thickness is between 9 to 11 mm in case of IUI. So we will take into consideration endometrial thickness also. Okay, so this is a very nice retrospective cohort study that relates that whether the optimum follicular size vary between clomiphene citrate and gonadotropin treatment. Yes, we have already discussed that in CC cycles, the average size of the dominant follicle will be little on the higher side, that is about 20 mm, 20 to 21 mm. And in case of gonadotropin cycle, which is around 18 to 19 mm. So we will trigger in our IUI cycle when the dominant follicle reaches between 18 to 19 mm. Effect of follicular diameter at the time of ovulation triggering on pregnancy outcome. Yes, definitely. Definitely, there is a role of optimum follicular diameter and pregnancy outcome. So what is the optimum follicular diameter in case of Letrose? In case of Letrose plus gonadotropin, that is gonadotropin stimulated cycle, the optimum diameter varies between 19 and 20 mm. So we will not wait for more than 20 mm. 18 to 20 mm is our limit. But we need to take into consideration that along with this, we need to take endometrial thickness into account also. So this is a very simple math that as the number of follicle increases, the result is going to increase. The success of IUI also increases. But at the same time, we need to keep in our mind We cannot afford OHSS in IUI cycle, so we need to keep in our mind the strict cancellation criteria, which I mentioned earlier. Now moving on to Doppler. First of all, I just want to ask you guys a question, that how many of you do the routine use of Doppler in case of IUI in your clinic? I don't know. We routinely don't do, but yes, literature-wise, there is a very good role of follicular Doppler in case of IUI. Now let's study. There are 3 Dopplers in case of IUI: uterine artery Doppler, endometrial Doppler, and follicular Doppler. The studies have came that uterine artery Doppler, endometrial Doppler has no role on clinical results, but yes, the follicular Doppler do have a role. So, which are the parameters which you will consider? This is a very nice prospective study of more than 1000 IUI cycles over a period of 10 months. And it has taken into consideration follicular RI, follicular PSV, and follicular volume. So, as you can see that the mature follicle, what is the definition, Doppler definition of mature follicle? That the follicular RI of Doppler mature follicle will be less than 0.5, and the PSV will be between 11 to 15 centimeter per second. This is the Doppler definition of mature follicle in IUI. What does it suggest us? That it will give you the optimum result, because this is the optimal maturity that we can get. If the peak systolic velocity of the follicle is more than 15 centimeter per second, what does it mean? It means that your follicle is in imminent rupture phase. You need to do double IUI, or you need to do the IUI 12 hours earlier. So the conclusion is, obviously the follicular Doppler do have a role. The presence of stimulus, which can be confirmed by 3D ultrasound, increases the surety of the presence of a mature cumulus in follicle. The effect of endometrial thickness and endometrial blood flow on pregnancy outcome in IUI cycle, as I have mentioned earlier, it is not going to make a big difference. So no role of endometrial Doppler, no role of uterine artery Doppler. This is the same study. Predictive value of uterine artery PSV on the success rate of IUI. It is non-significant to decide the prediction of pregnancy outcome. Okay, so out of 3 Dopplers, only follicular Doppler, and that too in follicular Doppler, follicular RI, and follicular PSV. Okay, now something we have triggered, we have seen that there is a mature follicle. Now, whether we will go for single IUI or double IUI. Now the studies have came and they are very reassuring that double IUI is no. So this is a very good meta-analysis which has analyzed almost 15 studies encompassing more than 3,500 women. And what does it conclude? That currently in the era of follicular Doppler, in the era of so good ultrasound available with all of us, there is no evidence currently to support the use of double IUI in clinical practice. Okay, so no significant benefit of double IUI over single IUI. Okay, so finally, the third step of optimization, that is what will be used in our trigger and how will we decide the trigger, and is there a role of Doppler or not. We would like to conclude that yes, we will routinely use the trigger in IUI. We will not go for natural cycle IUI. HCG trigger is more effective, but agonist trigger can also be thought of when we have a fear of converting our IUI cycle into IVF due to OHSS. Maximum pregnancy rate can be achieved if IUI is performed 36 to 40 hours. Doppler is definitely useful, but only follicular Doppler, and that too only RI and PSV. No uterine, no endometrial Doppler. And double IUI has at present in the current scenario no significance. Okay, so we have completed one cycle of IUI. We have decided the trigger, and patient will come 36 to 38 hours later at our clinic for performing IUI. Technical optimization. There are 2 technical optimization: the semen preparation technique, and second, the technique of doing IUI. So it's a very nice compact meta-analysis that is recently published in, I think, 2017. That compares every step of semen preparation. How do we process? How do we collect? how much interval which will we keep between the preparation and the procedure, and it's a very nice sum up. And I have just made a small conclusion out of this very big data, that first thing, what we will advise, how much days of abstinence. Any couple will ask us that what we need to take care that our IUI results will be like, wow. So nothing much, just a routine advice, ejaculatory abstinence period of up to 3 days, not longer. Then no significant positive effect of bed rest. So there is no need to counsel anything for rest. Ultrasound guided IUI doesn't result in higher pregnancy rates, so no need to do some high-fi IUI. Your simple IUI without ultrasound guidance is fine. Yes, this is a good point, that avoiding long time intervals between semen production and processing. This is a very important point for those clinicians and those obstetricians, those who don't have their in-house semen preparation, right? So for them, I would like to advise that more than 1 hour is not beneficial. More than 1 hour will do harm to your semen sample. So try to cut short that time and perform IUI in between 45 to 60 minutes. Centrifugation and storage at room temperature yields good results, so no need for hi-fi techniques. And this is just from the point of view of andrologist, that bitter and buffered media might be preferred over bicarbonate buffered media in case of semen preparation. Okay, so we have, yes, the second point I would like to talk about is the method of sperm preparation. There are 2 routine methods that we will use. A swim up method and the second is density gradient method. In all cases, I mean, like, except those semen sample that shows infection, debris or presence of leukocytes, the swim up method is good. So a routine swim up method will work. Only in the case of these kind of semen sample that has more infection and debris, you will use density gradient method. Okay, I'll come to that also, evidence based. Okay, so how will you perform IUI? Will you perform a bolus IUI or will you go for slow release examination? So it is a very nice multi-center randomized controlled trial that compares the routine IUI, that is bolus IUI versus slow release insemination, and it leads to important conclusion that pregnancy rate might be improved by using slow release insemination. But there is no consensus that we need to perform IUI in 10 seconds or 15 seconds or 30 seconds or 1 minute. In layman, in simple words, you will not insert like a bolus. You will just be slow, you will be gentle, and over the period of, I think, 10 to 15 seconds, you will perform one gentle IUI. And yes, compared to bolus IUI, it gives a better results. So what we will conclude? In technical optimization, we conclude that the optimal time between the preparation of semen and your technique, that is performance of IUI, should not be longer than 1 hour. So it is 45 to 60 minutes. Slow release insemination is better. Single IUI is preferred. And swim up in case of normospermia, and density gradient should be the method of choice in other cases. And I have already discussed which are these other cases. The cases which shows infection, debris, or more number of leukocytes in semen sample. Okay, now what about the luteal phase support? Will you give luteal phase support? In the era before 5 years, there were no meta-analysis which concludes that giving luteal phase support results in benefit, because you know that in IUI we have corpus luteum with us. But then recently the data have came up. It's a very recent meta-analysis. It's a very good study involving more than 2,500 patients undergoing more than 4,000 cycles of IUI. Total 11 studies were analyzed. And what do they conclude? They conclude that gonadotropin, when we use, it definitely leads to some physiological delay in luteal phase or some physiological shortening of luteal phase. So yes, it does affect the live birth rate. So when we go for gonadotropin and letrose IUI, it's better that we use luteal phase support. In case of CC, as we all know that the mechanism of action of CC is it blocks the hypothalamic estrogen receptors. It's a delayed effect, so it blocks the receptors for quite a long time. That leads to feedback related release of LH. So in case of CC, there is no need of luteal phase support, but there is no such effect with gonadotropin and letrozole. So yes, in gonadotropin plus letrozole IUI, we will definitely go for luteal phase support. So yes, in conclusion, exogenous progesterone, that is luteal phase support, will lead to improvement in both clinical pregnancy and live birth rate when we are performing IUI with gonadotropin and letrozole. So the conclusion is we will go for luteal phase support. At our clinic, we are giving progesterone gel OD or Dufast on BD for 14 days. Okay, so finally, in case of luteal phase support, we would like to conclude that evidence-based, there is a significant effect on clinical outcome when we are performing IUI with gonadotropins. So we will definitely give the luteal phase support. And as I have said earlier, we are preferring to give gel OD or oral dydrogesterone, that is Dufast BD for 14 days. Okay, so it's a very burning question in today's era that how many cycles of IUI should be performed? 6, 9, 3, 1, how many cycles? Okay, and what is the success rate? So this is a review and systematic assessment of the evidence that supports global recommendation. And what is the question? What is the ultimate number of consecutive IUI cycles per couple that we should perform that will have any effect, significant effect on our pregnancy rate? So as you can see, the draft has recommended that in the couples with an indication for IUI that we have discussed earlier, proper indications of IUI as per the ASRM, at least 3 consecutive IUI cycles should be performed. But there is no recommendation regarding maximum number of IUI cycles. But it's a very nice study that there is no recommendation regarding the maximum number of IUI. But as you can see that more than 3 IUI will not increase the success rate. So in today's scenario, I think there is no point in doing more than 3 IUI because more than 3 IUI will definitely not increase, but rather than it will decrease the success rate, right? But again, along with the number of IUI, we need to take these factors into consideration, the age of the patient and the indication. Now, if the patient is young, like say less than 30 years, duration of infertility is less than 5 years, unexplained infertility, everything is fine. So obviously, I will wait for 3 cycles. But if the patient is more than 35 years, low ovarian reserve, active marriage life 7 years, duration of infertility 7 years, so in that case, I'm not going to wait for 3 cycles, right? So basically, finally, it depends on the psychology, it depends on the financial status, and at the end, it depends on the indication. Okay, so so at last, I would like to throw some light on the factors that influence the success rate. Which factors we will take into consideration? Age, obviously, female partner's age, duration of infertility, type of infertility, cause of infertility. In today's era, medication used, no, because we are very comfortable with IUI and letrozole. Number of IUI cycles we have already discussed. Endometrial thickness, number of follicles in relation to AMH. So these are the factors, and you will take into consideration, and you will divide your patient into good prognosis and bad prognosis depending on these factors. See, this is the chart, or this is the plan of treatment that we will decide in our mind. Good prognosis patient. What do you mean by good prognosis patient? When the duration of infertility is less than 2 years, age of the female is less than 35 years, unexplained infertility, tubes pattern that has been documented, you can definitely go for 3 cycles of IUI. It should be performed. But in bad prognosis patient, where we don't have that much time, where the duration of infertility is more than 3 years, age of the female partner is more than 35 years, we will think after each IUI, and we will restrict the number of IUI after having proper discussion with our patient. At last, I would like to say that each IUI should be audited. You should discuss after each IUI. You should sit with your patient and evaluate each and every factor, that whether to go for the second IUI will lead to higher success rate in these patients. If no, there is no point. You can move directly to IVF in today's era. Okay, so you have selected your patient, you have performed IUI, you have given the right trigger, You have given the luteal phase support. You have taken all precautions into consideration. You have performed IUI. After 14 days, patient came. Beta HCG negative or UPT negative. There is no pregnancy. Fails. Now, what will you do? How will you proceed? First of all, you sit with your patient and you audit your IUI. Which questions, how will you audit and which questions you would ask? First, was your patient selection proper? Was your trigger appropriate? Was the sperm count and motility pre-wash and post-wash you have taken into consideration? Was it a difficult IUI? Whether to go for second IUI? Explain patient the success rate of IUI and its limitations. So on the day of your consultation, when the patient comes and your result of IUI is negative, you will talk on these many topics with your patient before deciding any other line of treatment. What can be the reasons of failure? Why your IUI has failed? It can be genetic reason, either the quality of the sperm or quality of the egg can be poor, which we cannot evaluate. Age of the patient, quality of the sperm, timing, endometrial thickness, ovulation problem, or inadequate progesterone support. So as a clinician, you will ask these questions to yourself and then you will counsel the patient whether to go for second IUI or whether to go for some aggressive approach. Okay, now difficult IUI. I would like to throw some light on difficult IUI because there are studies relating the difficult IUI and clinical pregnancy rate. So difficult IUI means difficult negotiation. So what are the steps that we can take to optimize the technique of IUI? If there is difficult IUI, if you are not able to negotiate the cervix, what will you do? What will you do? First step, very simple. You can ask your patient to partially fill up her bladder. That will naturally correct your uterocervical angle and will make easier for you to negotiate. Then even if it is not possible, what you can do, you can catch the cervix, single catch to straighten the uterocervical canal. And you can use USG. You can do USG guided IUI. Again, difficult negotiation. The last step, you can use steel cannula, which is a hard cannula. Normally we do IUI with a semi-soft cannula, I think made up of silicone. But in these cases, you can go for steel cannula, which will have two rods. It will help us to dilate the cervix. At the same time, it will help us in negotiation. Still, if you are not able to negotiate the patient, you can go for IUI under anesthesia. This is the last step. IUI under anesthesia and ultrasound guidance. Now, I would like to ask these questions to you guys that what will you do in these situations? This is a very routine kind of situation that each and every clinician might encounter. The patient had come to you previously, you have counseled for IUI and now you have just advised them to follow up on second, third day of menses. Patient arrives. Patient arrives with a simple cyst of 3.5 by 3.5 or 3 by 3 centimeter. What will you do? Will you start IUI? I will not start. Okay, patient comes for trigger on the 9th or 10th day. You have given, let's say, FSH, 62.5 or 75 IU daily, but there is no dominant follicle. What will you do? It's possible that in case of hypogonadotrophic hypogonadism, hypo group, where the FSH and LH are lower, it may be possible that the lower dose of gonadotropin might not lead to dominant follicle. So, of course, I will cancel the cycle and I will order serum FSH and LH. Okay, now husband has fever before 2 days of IUI. What will you do? Will you cancel? No, we will not cancel the IUI. We will just counsel the couple that yes, fever and the acute inflammation in your body does play a minor role in your semen parameters, but it's okay. We can take optimum precautions. We can use swim up and density gradient SOS, and we will prepare the husband's semen. But yes, we will definitely counsel the patient that fever has effect on semen parameters. We will do the counseling part. On difficult IUI, we have discussed. What precautions will you take? We have already discussed. OHSS in IUI, what are your views? Yes, OHSS can occur. We have discussed one solution. We can use agonist trigger in next cycle. And in today's era, I think it's better to go for IVF, where we have a wonderful antagonist protocol with us that nearly eliminates the risk of OHSS. Okay, so role of newer logistics in IUI, role of centrifugation, role of microfluidics, role of sperm function test. See, each and everything depends finally on the clinical feasibility and the economic approach. Now, if I work in a condition where the demography of my patient is like very low socioeconomic class, I will not think of that. But if my demography, patient demography is really, really nice, and if they are educated above some level, they are ready to accept the science, they don't want to go for IVF, they are ready for the conventional approach, they are young, they are good prognosis patient, repeated IUI failures, still wanted to go in IUI, then I will think of using this advanced scientific techniques that I'll come to you later. See. Effects of shaking and centrifugation on human sperm motility. So they have evaluated the sperm motility before shaking and after centrifugation, and 5, 10 and 20 minutes after centrifugation, and they concluded that there is the harmful effect of vigorous centrifugation and shaking may be attributed to intracellular damage or leakage of vital components from the unprotected and delicate cellular membrane. So no need to use these hi-fi techniques, no need of centrifugation in case of IUI sample, right? Sperm function test. So will you use sperm function test before IUI? I think clinically, practically, I think we all know we are not using this kind of hi-fi test in case of IUI. This is one prospective study. They have studied almost more than 90 couples. And they said that there is 3-fold higher result in sperms with high fertilizing potential after testing the acrosome reaction. But do you think that your demography will support the use of sperm function test in IUI? If the count and motility is good, I think in IUI we don't need anything else. So what do you really do in your clinical practice? Do you use this fancy test in IUI? No, we will not use. There is no need. This is the other test that is going to measure the oxidative stress. And it says that in the semen samples which have the oxidative reduction potential levels twice higher among the infertile men. But again, this is a kind of test just like DFI. It's for counseling purpose, that you are telling patient that I am not wrong, the clinician is not wrong. See, this is wrong. Your oxidative stress is there. Your DNA fragmentation test or result is high. That's why you are failing. So do you actually measure ORP in your practice? No, not definitely in IUI. No, we are not going to do that. It's important only from the counseling point of view, right? Yes, this is the same thing that we have discussed previously regarding the DFI. The routine use of DFI is not recommended. Microfluidics, obviously, it helps us to select the good sperm in case of IUI, but in case of IUI, we will never use the microfluidics because it is simple, but at the same time, it has its own cost. Yes, but in those couples who are very, demography-wise good and good prognosis patient, younger patients, everything normal, previously 3 or 4 IUI failures, still want to go for IUI, not at all ready psychologically, physically, and financially for IVF, but ready to spend for IUI, then we can think of some 1 or 2 things like microfluidics and DFI for counseling. Microfluidics for technique, but DFI definitely for counseling. It's a very recent development, so more data will, I think, make our IUI study more clear, but to date, nobody recommends the routine use of microfluidic. Okay, so after studying this much, actually now what to implicate? So every clinic has to basically decide its own protocol based on what? Based on their patient demography and clinical experience of herself or himself, and what resources, what kind of resources you have. And oh, it's better not to over centrifuge. So that question is just omitted. You need not to centrifuge your DFI, your IUI sample. Swim up technique is the best, and density gradient will you use only when the semen sample contains infection, debris, and leukocytes. DFI only for counseling purpose. And mild male subfertility is associated with advanced age of both the partners. So again, more than 35 years, couple not ready for IVF, you will counsel regarding what are the results of IUI and what is the role of IVF in these kind of couples. Okay, so when you will think of moving on from IUI to IVF, it's a very nice trial. The name of this trial is fast track, faster approach. What they have done is they have decided the two arms. The first arm is conventional arm that includes 3 cycles of CC-IUI, that is CC cycle, then 3 cycles of gonadotropin IUI, and then up to 6 cycles of IVF. This is the conventional arm 1. And arm 2 is the accelerated arm that has omitted the 3 cycle of FSH-IUI, practically omitting IUI and moving on from just CC-IUI to IVF. And main outcome, what they measured was the time to take the pregnancy, the time to take the live birth, cost effectiveness. Okay. And what have they concluded? These are the results. Increased rate of pregnancy, decreased time of pregnancy interval was observed in accelerated arm compared with the conventional arm. Per cycle pregnancy rate, CC-IUI nearly 8%, FSH-IUI nearly 10%, IVF nearly 3 times more. But these we are talking about the fresh cycle transfer. In today's era, where the world is moving towards the frozen embryo transfer, we can increase these results to more than 65 to 70%. So again, these are the recommendations given by Canadian Fertility and Embryology Society. It's a very nice summary. They have evaluated each and every study that compares the IUI and IVF. You can see that the pregnancy rate almost nearly doubles or nearly triples when we compare IUI and IVF. When we per cycle, nearly 1/3 more, 7.8 compared to 12. Then after 3 cycles, nearly more than double. Again, 17% after 3 cycles of IUI and 22% per cycle IUI. So what you can just think in your mind that in today's era, 7 cycles of your IUI means 1 cycle of IVF. So you guys can think what is better in which case. So what they concluded that there is nothing wrong in offering IVF as a effective first-line treatment in case of unexplained infertility. There is nothing wrong in that. IVF should be offered to couples with unexplained infertility definitely after 3 cycles of IUI. So 2 conclusions. Not more than 3 cycles of IUI, ending bad prognosis patient, nothing wrong in going for direct IVF. This is a study that just compares the IUI and IVF on the basis of success rate and cost. So as you can see that definitely age-wise, success rate-wise, IVF is more than double. Over 40, nearly double. Okay. Again, what do we take into our mind? Whether to do IUI or IVF is a decision made in collaboration between patients and their doctor. Depends on 3 things: psychology, financial status, and physical involvement that the female is ready to take. What are the factors that will influence? Patient's age, yes. Diagnosis of infertility, yes. Budget, insurance coverage, personal preferences. These all things you need to take into consideration before deciding whether to go for IUI or IVF. See, this is the $1 million information. The pregnancy rate that you can achieve by timed intercourse 4%, IUI 6, CC-IUI 8, gonadotropin IUI 8, good prognosis gonadotropin IUI nearly 12 to 15%. IVF 20 to maximum 40, but this is fresh cycle. 50 to 60% with donor cycle. In case of frozen embryo transfer, The self-cycle success rate increased up to 60 to 70% and the donor cycle up to 80%. Okay, so this is a very recent trial which has not been completed yet. It is a fixed study. The results are pending. But I would like to just show you the layout of this study. It's a multi-center open-label randomized control trial involving 580 couples. What they have done is they have evaluated 2 arms after randomization. One arm 4 IUI plus 2 IVF, and the second arm only 2 IVF. Results are still awaiting. So after this trial, I think we all will have a cost-effective decision that whether in bad prognosis or in moderate prognosis patient, whether to go for IUI and then IVF or direct IVF. Okay, so something about poor responders. What do you guys really do? Like just say more than 35 years patient, low AMH, not more than 1 to 2 antral follicles in both the ovaries. What are your views and clinical experiences? This is a very nice study. They have used Bologna criteria and they have evaluated the poor responders. That how to decide that in poor responders, when you will opt for IUI and when you will opt for IVF. Okay, so at least what they have concluded that pursue IVF for women demonstrating 2 follicles. At least whenever there are 2 follicles also, it's good that if you do a controlled ovarian stimulation, and controlled ovarian stimulation means IVF, and to convert to IUI for cycles with only 1 follicle if the sperm and tubal parameters are favorable. So if there is 1 follicle, okay, IUI. But even if there is 2 or more than 2, definitely IVF. Because as you can see that when the follicle will be around more than 16 mm, the early pregnancy and the live birth compared to IVF and IUI, it is 11.6 and 1.6, nearly 10 times as compared to IUI. This is that confirmed trial, which the results of which are awaited. Primary analysis, I think, will be completed around 2022. So we are waiting for that. Okay, so what do we conclude? That it's a low success rate treatment. Yes, efficiency wise, when we compare to IVF, definitely. Every IUI should be audited. Yes, you should sit with your patient. You should analyze each and every factor and you should audit your IUI. Again, there is no exact consensus regarding the maximum number of IUI, but we have concluded that more than 3 IUI will not lead to increased success rate. So more than 3 IUI not recommended in any case scenario. So more than 3 IUI at any age are not recommended as the success of IUI does not improve after that. Decision to restrict the number of IUI should be made by joint collaboration of patient and doctor. Okay, so thank you.